Miss Awesome is a 90-year-old female who presents complaining of a cough for over a week. In addition to having chest tightness over the last day or so, she also reports having a non-productive cough at baseline for several years. She admits to having similar symptoms to this multiple times in the past, the most recent episode being 1 month ago, treated by her PCP with a course of Augmentin and Prednisone. The patient has a history of COPD, hypertension, hyperlipidemia, type 2 diabetes, nicotine dependence. She smokes 1 pack of cigarettes per day. She currently takes lisinopril, simvastatin, metformin, Convidant, Risperdal, and Montelukast as directed. No known drug allergies, up to date on all immunizations. Her brother does have a history of oral cancer secondary to tobacco use. Review of systems is unremarkable except for the patient endorsing a productive cough with yellowish white sputum and bilateral rib pain with the cough. Her vitals are stable except for she's sitting at 88% on room air. On her physical exam, she's alert and oriented ×4, appears uncomfortable in mild to moderate respiratory distress. Despite being slightly tachycardic, she has no murmurs, rubs, or gallops. She has 1+ pitting, pedal edema bilaterally, and poor skin turgor. Her respirations are labored and tachypnic. Accessory muscle use is noted, and inspiratory and expiratory wheezing is appreciated diffusely throughout her lungs bilaterally. Rhonchi is noted in the patient's mild to lower lung field bilaterally, and she does speak in 4 to 5 word sentences at a time. Has mild atrophy in her upper and lower extremities bilaterally. The rest of her physical exam was unremarkable. So currently she has a CBC, CMP, cardiac biomarkers, D-dimer, ABG, UA, and COVID PCR all pending. Her influenza and RSV rapid antigen tests are all negative. Chest x-ray shows bilateral hyperinflated lungs, diaphragmatic flattening, and a slightly elongated cardiac silhouette, and her ultrasound was normal. So at this time, my differentials are COPD exacerbation, community-acquired pneumonia, asthma, bronchiectasis, pulmonary neoplasm, TB, pulmonary embolism, if I didn't already say that, and heart failure. So the most likely diagnosis is going to be acute exacerbation of her previously diagnosed COPD. Pertinent positive for this is severe breathlessness, cough with sputum production, wheezing to auscultation, chest tightness, low SpO2 values. I am highly suspecting that her history of similar symptoms are exacerbations, and her smoking history puts her at high risk. So to evaluate this further, PFTs will be performed, sputum will be obtained for Gram and AFB stains. So based on her state, I recommend she be admitted. In addition to starting her O2 via nasal cannula, probably starting her at 6 liters right off the bat, she should be given an albuterol nebulizer treatment by respiratory IV systemic corticosteroid, prednisone would work, and antibiotics. So since I highly suspect she has a history of multiple exacerbations in the past, and she does have that recent antibiotic use within the last 3 months, I would choose Cipro as the antibiotic to go with, and then we can reassess her plan when the sputum cultures come back, while continuously monitoring her in the hospital, and then lastly, obviously encouraging her to quit smoking and offer her smoking cessation aid.